This webinar is kindly supported by Convatec and SSI. The supporting companies have not had any influence on the content of the webinar. We hope you will enjoy the webinar. This webinar is kindly supported by Convatec and SSI. The supporting companies have not had any influence on the content of the webinar. We hope you will enjoy the webinar.
Good afternoon, everyone, and thank you for joining us. My name is Sebastian Probst. I'm a professor of tissue viability and wound care at the University of Applied Sciences and Arts, Western Switzerland, the University of Geneva, and current president of EWMA. I will be moderator of the webinar. This webinar is the first episode in a series of 3 webinars focusing on the various aspects of surgical site infections and antimicrobial stewardship. The webinar is based on the EWMA document, Surgical Site Infections, Prevention and Management across healthcare sectors, published in 2020. This time, we focus on epidemiology, prevention, and diagnosis for surgical site infections. The webinar will be recorded, so you will be also able to watch it on demand after a few days. We will be able to request a certificate of attendance for the live participation in the webinar if you participate in minimum 70% of the live webinar. A link to the certificate will be sent after this webinar. The 3 speakers will each speak for 10 to 20 minutes. After this, there will be time for questions. Please note that you can type your question in the Q&A box anytime. I'm now pleased to introduce the presentations and welcome the speakers in today's webinar. Our speakers are Kylie Sandy Hodgetts. She's a senior research fellow and senior lecturer in the Faculty of Medicine and the director of the Skin Integrity Clinical Trials Unit, University of Western Australia. The second speaker is Deborah Schwer. She is a senior infection prevention and infection control nurse at Mater Dei Hospital in Malta. And the third speaker is Janstria. He's a vascular surgeon in the Center of Vascular and Mini-Invasive Surgery, Hospital Podlesi, and the Slavatella Center of Non-Healing Wounds Treatment in the Czech Republic. The presentations today are pre-recorded, but all speakers are present and will take part in the Q&A session in the end of the webinar. So now I would like to start the first presentation by Kylie Sandy Hodgetts, who will talk about epidemiology, signs and symptoms of surgical site infections. She will be followed by Deborah Schwer, who will talk about preoperative precautions for surgical site preventions. And as the last speaker, Janstria will talk about classification of surgical site infection and surgical wounds. Please do add any questions you may have for each speaker in the questions box at any time during the presentations, and we will address these after the last presentation. We hope you will enjoy the presentations.
Hi everyone, Dr. Kylie Sandy Hodgetts here. I'm delighted to join you in this educational webinar series brought to you by EWMA and the team that put together this great document, Surgical Site Infection Management Prevention across healthcare settings. So today I wanted to talk to you about the epidemiology and signs and symptoms of surgical site infection. So let's get underway. I have no conflict of interest to declare in relation to this presentation, and now we'll begin. It's really important to understand just how much surgery is being performed each year, and there's an estimated 313 million surgeries conducted annually around the globe. That's quite a considerable amount of surgery. An incisional or normal wound healing usually occurs within 72 hours of the insult to the skin integrity. If we've got a healthy patient, we can anticipate 6 to 8 weeks for full closure. Complications such as infection or dehiscence do occur, and they can be related to patient-related factors, intraoperative procedures or post-operative wound management. There's a whole plethora of risk factors associated with surgical site infection. This will be discussed by my fellow colleagues in other presentations. The most commonly reported time for a surgical wound complication, such as infection, is usually in the post-operative period. So it's between day 7 and day 9. And what we're finding now is that surgical wound complications like infection are more commonly managed in the post-discharge surveillance setting. So that's community nursing and primary health care. But it's really important to understand what a surgical wound complication is. And it is a cluster or an umbrella term that is defined as a disruption to normal incisional wound healing following surgery. And this is a consensus-derived definition that broadly encompasses other well-known clinical definitions such as surgical site infection, surgical wound dehiscence, hypergranulation, peri-wound maceration, scarring and medical adhesive related skin injury. But for the purposes of today's webinar, we are going to talk about surgical site infection. So let's talk about the definition. So a surgical site infection is an infection that occurs after surgery in the part of the body where the surgery has taken place, and it is usually related to contamination of microbes. And the Centers for Disease Control first came up with a validated definition in the 90s that is the most commonly used definition, a reporting definition for the healthcare setting. And they classify it in 3 ways, there's 3 components to this definition. You have superficial, incisional, deep incisional or organ space. And the time frame for this to occur is usually between 30 to 90 days in the post-operative period. So it's been extended out to 90 days to incorporate orthopedic or implant surgery. It is demarcated by clinical signs and symptoms such as purulent drainage and fever, and I'll go through clinical signs and symptoms towards the end of the presentation. But the diagnosis is made by the attending physician or consultant or medical attendee, RMO. And microbiological confirmation is specified for organ space, and it is optional for superficial or deep infection. Surgical wound dehiscence, which doesn't really obtain that much attention, and it's quite often lumped in with surgical site infection as an organ or a deep space infection, can occur. And there's 2 factors here that you need to consider. You need to consider whether the wound breakdown is related to microbial or pathogenic activity, or whether the breakdown is due to non-microbial causes. And there is a specific grading system that was published in 2017 and subsequently adopted in a World Union document that grades surgical wound dehiscence. So we have a number of grading or classification systems in wound care, like skin tears or pressure injuries. This is specifically designed to grade surgical wound breakdown, particularly when there are non-microbial factors at play. So please do avail yourself of the SWD grading system, and it fits quite nicely with the ICD-10 classification for surgical wound dehiscence. Our surgical colleagues do have a couple of other diagnoses or grading systems for wound infection when it does occur. There's a Southampton wound score, which was published in the 90s by Bailey et al. And it is a wound scoring system that grades the clinical signs and symptoms. It's the most commonly used one in publications. And it's not necessarily a reporting definition, it's more of a clinical definition. The asepsis wound score, which was published in the 80s in the Lancet, was originally devised to classify wound infection in clinical trials when they were looking to use antibiotic prophylaxis in prevention of SSIs. Interestingly, it has been subsequently used in many clinical trials and studies around the world, and it is a well-validated wound scoring system that is used in the surgical fraternity. So let's talk a little bit about surgical site infection, the incidence and prevalence, and just how big of a deal it really is around the world currently. And in 2002, the estimated incidence rate in the US was around 4.5%, which meant a 9.3 infections per 1,000 patient days, or 1.7 million infected patients in the USA. The European Union, the audit of healthcare acquired infections was an overall point prevalence of 5.7%. And it's reported by Hake et al. That SSI is the third most commonly reported healthcare acquired infection. If we have a bit of a snapshot looking at what is currently reported in the literature, and unfortunately in the literature its pooling of data is confounded due to inconsistencies in measurement and definitions, but we can generate or gather a snapshot of what's happening around the world. And there we have some rates from the Middle East, India, Asia Pacific, Oceania, and Europe more specifically. And there you have the prevalence and the incidence reported there from Benedetta Alexandria's work with the World Health Organization. What we're finding now is that surgical site infection and wound dehiscence are more frequently managed in the post-discharge setting, and that is in the community and nursing setting, and due to early discharge rules in most acute care settings. When we're trying to understand the epidemiology of surgical site infection, we do have a fair amount of data on the economic burden of SSI, primarily in the acute care setting. And this infographic tells you quite nicely the cost in the acute care setting, and this is attributable to extended lengths of stay, readmission for the surgery, and the extended resources and nursing skills that are required to manage this type of wound. So what is the big deal when it comes to surgical site infection? Why is it so important that we're trying to prevent this from occurring across different healthcare sectors? And unfortunately, you're 2 times more likely to be admitted into ICU if you do incur a surgical site infection, 5 times more likely to be readmitted for further surgery, 2 times more likely to die. The morbidity rates are quite high if you do incur a surgical site infection. And in the community nursing setting, whilst there is a deficit in the academic literature in regards to the cost burden of this type of wound, a recent study conducted here in Western Australia yielded some interesting information around the cost burden for managing this type of wound in the community nursing setting. And it's quite an expensive wound to manage. It's twice that of those of non-infected wounds. Unfortunately, if the surgical site infection is associated with MRSA, your morbidity is not looking that good. You're 12 times more likely to die. There is also major work to be done in post-discharge surveillance and in particular reporting. There are considerable inconsistencies in diagnosis and reporting that needs to be improved in the healthcare setting. So when we're assessing for surgical site infection, we look for the traditional clinical signs and symptoms, and that it has been like that for quite some time. So it's a clinical assessment for the presence or absence of particular types of signs and symptoms. So that is fever, erythema, purulent exudate, odour or breakdown of the associated peri-wound skin. The gold standard for infection diagnosis is the swab or a tissue biopsy. The wound swab for a bacterial culture is a less invasive procedure compared to a tissue biopsy, and you can gather a fair amount of information from a culture. You can use gram stain along with other staining techniques that allow for the bacteria to be evaluated under the microscope and potentially diagnose what type of pathogen you're dealing with. Tissue biopsy can be quite costly, it is invasive and can be painful. And although it does tend to give you a very accurate picture of what's happening under the wound bed interface, which is quite commonly associated with investigating a biofilm activity. Bacterial wound culture is the primary test that's used to determine the cause of a bacterial infection. And this can inform your antimicrobial strategy with that particular patient and whether or not to prescribe antibiotics in the clinical setting. The clinical signs and symptoms of surgical site infection, the classic table that is mostly used in clinical practice is that of the Centres for Disease Control, and there's a reference down there for you to access. And there are key characteristics for superficial, deep or organ-based symptoms. And they are referring specifically to the host inflammatory response and the development of the chronicity of the infection itself. I think what is important moving into the future, moving beyond improvement in diagnosis, is early detection and advances in diagnosis using more accurate techniques such as advanced light therapies or specific diagnosing testing is key in prevention and stopping the wound from escalating into a chronic, more complex wound to manage in the healthcare setting. Post-operative incision management is most effective across a multidisciplinary team approach. And when we're assessing, we need to take into account the patient-related factors such as the home setting, lifestyle, demographic and socioeconomic background. There needs to be a fairly good post-discharge surveillance system, and some of my co-authors will talk to this in other educational webinars around this book. But there are a number of programs around the world. I think of Melissa Rochon's work in the UK and also the Edison trial here in Western Australia that's looking at developing a clinical model for post-discharge surveillance within the healthcare setting to improve outcomes. And it's a great resource for you to use in the clinical setting, no matter whether you're in primary or community nursing or even the acute care setting. There's some neat tips and tricks and also some great tables to reference guide for you to refer. So it's been a pleasure to work with the co-author team, and I hope that you enjoy this educational webinar series. I'd like to say thank you very much to Wounds Australia and EWMA for being part of the surgical site infections prevention and management across the healthcare settings sector document. Thank you.
Hello everybody, my name is Debbie Shwirap. I'm a senior infection prevention nurse in Mater Dei. I'm really honored that I had the opportunity to be able to work on this document with EWMA. Let me start by sharing my screen. Right, before I continue, I must acknowledge that I represent the Infection Prevention Society on the One Together Collaborative. This is a project which brings together several organizations within the UK which aim to raise the profile of reduction of surgical site infections within the operating theaters. Some of the figures which I use within my slides are produced from resources which the together collaborative has produced. The recommendations which we put forward in the EWMA document are based on the three main surgical site infection prevention guidance produced by the World Health Organization, by the CDC, and also by the National Institute of Health and Clinical Excellence in the United Kingdom. One must point out that the strength of the recommendations put forward varies depending, of course, on the available evidence at the time. What are the factors which affect the risk for surgical site infections? There are a multitude of factors, some pertaining to the patient themselves and others on what happens within the operating room, relating to how much of the microorganisms manage to reach the surgical site. And some, of course, the preventive measures address these risks. We start by looking at the preoperative phase. What factors can we try and influence to reduce the patient's risk for surgical site infection? The first suggestion is to screen all patients undergoing high-risk surgeries, mainly cardiothoracic and orthopedic surgeries, for nasal Staphylococcus aureus carriage. And the literature reports that around 20% of the patients would be carrying Staph aureus. And so it is, and this is a main, it is considered as a major microorganism which causes surgical site infection. So it is worth investing in a screening and decolonization program preoperatively. Whether other surgeries should be, patients undergoing other surgeries should be screened for Staph aureus carriage depends on local epidemiological data of surgical site infections. Patients should be encouraged to shower before surgery so as to ensure that their skin is clean and the transient microorganisms at the surgical site are reduced as much as possible. There is no evidence to use antiseptic soap at this stage, so patients can use normal soap before going in for surgery to have a shower. Hair removal is considered as one of the factors which has most been researched and where there is most evidence supporting the recommendations. There is several RCTs show that there isn't the need to have the hair removed as a measure to reduce surgical site infection risk. However, this may be required to have access or to view the operative site better. If hair is removed, then this should be done using hair clippers to minimize the damage to the skin. If shaving blades are used, it has been reported that this actually doubles the risk of wound infection, as the blades of the skin actually cause small cuts on the skin, which then help bacteria to multiply at the site where the hair has been removed. As you can see in my slides here, this is the picture of the skin prior to shaving blades being used, and here you can see the nicks which at times are not visible to the naked eye, but these of course will attract bacteria to the surgical site. Warming is a big factor, so actually body temperature is a big factor on the surgical site infection risk. In fact, NICE actually published guidance separate for the prevention of inadvertent hypothermia. So hypothermia is defined as a body temperature of less than 36 degrees. And this is obviously then associated with an increased risk of surgical site infection. It is suggested that the patients are assessed for the risk of hypothermia. Basically, it is suggested that any patient who is undergoing surgery which is longer than 30 minutes, they should be actively warmed before going down to the operating room. Of course, none of the patients should not be transferred to theater if their body temperature is below this temperature. It is suggested that a direct measure of or estimate of core temperature is performed, generally by using measures such as sublingual or axilla monitoring devices rather than invasive devices. So once the patient reaches the intraoperative phase, there are several factors which one needs to look at or which one can influence to reduce the patient's risk for infection. The intraoperative phase is considered, of course, the period where the anesthesia is being administered and also when surgery is performed. The surgical team would perform a surgical scrub. Why is this done? This is basically to reduce transient microorganisms on the skin, on the hands, and it is recommended that an antimicrobial soap or alcohol-based hand drop are used. The NICE guidelines actually suggest that the first scrub of the day is performed using antimicrobial soap, and then subsequent scrubbing can be done using alcohol-based hand jobs. It seems that from the studies performed, it seems that chlorhexidine and alcohol-based hand jobs are superior to povidone iodine scrubs, and also that 3-minute scrub is better than 2-minute scrubbing. Once the patient is on the operating table, skin disinfection is necessary. Alcohol-based products are preferred, especially in areas where damage is not done by alcohol, such as mucous membranes. Okay, alcohol is preferred because it is fast-acting and it dries quickly. Povidone iodine, chlorhexidine and povidone iodine are both good skin disinfectants because they exert persistent activity on bacterial growth. However, the evidence seems to favor chlorhexidine over povidone iodine as a way how to reduce the amount of microorganisms at the surgical site. Surgical antibiotic prophylaxis, of course, is a major factor in surgical site infection prevention. The purpose of surgical antibiotic prophylaxis is to eliminate the microorganisms introduced in the surgical wound during the procedure. It is recommended that a single dose of antibiotic with a long enough half-life is given throughout the operation, and this is enough to protect the patient from infection. A repeat dose is only recommended if there is excessive blood loss or if the surgery is unexpectedly prolonged. Timing of the administration of the antibiotic is also important, and it is recommended that this is given at least 60 minutes before the incision, so as to allow the antibiotic to reach the targeted site before the incision is made. If the timing is not adequate, this may actually increase the patient's risk for surgical site infection. Again, intraoperative warming, this is also, of course, needs to be addressed during the surgery. And this is because the administration of general anesthesia, this often leads to a drop in the core body temperature, sometimes to even more than 1 degree. Of course, the environmental conditions within the operating room do not help, so these all can contribute to the patient having an increased risk for infection. Which patients should be warmed intraoperatively? This points that almost most patients would need to have some kind of active warming once the anesthesia has been induced. Also, NICE guidelines recommend that any patient requiring large volumes of IV or irrigation fluids, these should be warmed so as to reduce heat loss. This should be warmed using a thermostatically controlled cabinet. Okay, so this further reduces the patient's risk of getting cold. Postoperatively, of course, the patient's temperature should also be monitored at least every 15 minutes, and the patient should not be transferred to the ward unless their body temperature has reached 36 degrees. The surgical environment, as I referred to earlier, plays a significant role in the contamination of the surgical wound on the surgical field. So to reduce and minimize this risk, the operating rooms should require specialized ventilation, okay, which helps to dilute and remove airborne contamination. Basically, the ventilation in an operating room has several air changes per hour so as to minimize the transfer of microorganisms onto the sterile field. The World Health Organization refers to the use of laminar flow ventilation systems, which were previously recommended as a way to reduce the incidence of prosthetic joint infection. However, a systematic review and meta-analysis by Bischoff et al. Published in The Lancet in 2017 actually found that these systems, laminar flow systems, do not really offer advantage in terms of incidence of post-op surgical site infection when compared to the use of conventional operating theater ventilation systems. And so they recommend that new builds should not really look at installing expensive laminar flow ventilation systems. The other point which we must refer to is the movement of theater staff within the operating room and adjacent rooms, because of course the more movement there is, the more there is disruption and increase of risk of airborne contamination. Some surgical teams like to use incised drapes because they on the surgical site, because they believe that this secures and protects the incisional area. There isn't enough evidence to support the use of such incisional drapes as a measure of preventing surgical site infection. In fact, some studies also showed that these drapes actually increase the multiplication of microorganisms at the surgical site. The NICE guidelines, however, say that if an incised drape is going to be used, an iodophore impregnated drape should be looked at. Also, with regards to sutures, it is recommended that antimicrobial sutures coated with triclosan can be used, especially for pediatric surgery. Some of the guidance also point out there isn't enough strong evidence to suggest that the use of antimicrobial sutures, this is. It is also worth considering the use of sutures rather than staples to close the skin after C-sections, which helps to reduce the risk of superficial wound dehiscence. This is based of course, on studies which were done mostly on C-sections. Other two factors which can help reduce which can help reduce the surgical site infection risk of the patient are the administration of high percentage of oxygen during the surgery, and also, if possible, in the immediate post-op period, and also monitoring and controlling glucose. In fact, several observational studies showed that hyperglycemia can be associated with an increased risk of surgical site infection. There is, however, disagreement amongst the guidelines on the level of glucose control required to reduce the risk of surgical site infections. If we move on to the post-operative phase, there is reference to the type of wound dressing. So obviously a wound dressing is important to reduce the risk of surgical site infection. However, there is no definitive evidence for the type of interactive dressing used to prevent surgical site infection. What NICE recommends, however, is using appropriate interactive dressings, which are dressings which promote wound healing. More recently, there has been more publications on the use of negative pressure, and the guidelines say that the application of such wound therapy and prevention of SSI can be useful in reducing post-operative wound complications. What I want to refer to at this stage is that in the guidelines, in the EWMA guidelines, we have published a table which looks at the different wound dressings available for the management of surgical wounds, which can be quite handy for practitioners. The last point I want to mention is the use of surveillance as a measure of controlling or reducing surgical site infections. Surveillance involves the collection, analysis, and feedback of surgical site infection data, with the goal of focusing infection prevention and control efforts. And this, in fact, is seen as a key component of infection prevention and control programs. As a way, as a sustained surveillance has been shown to reduce rates of infection. What I want to point out at this stage is that feedback of surgical site infection rates to the surgical team is important to encourage ownership and active participation, of course, in any efforts to reduce surgical site infection risks. So in conclusion, all the recommendations or suggestions to reduce surgical site infection or to prevent surgical site infection look at minimizing the number of microorganisms introduced in the incision site, for example, through skin disinfection, the prevention of multiplication of microorganisms at the incision site, for example, by using prophylactic antibiotics, and enhancing the patient's defense against infection through perioperative warming, and then also preventing access of microorganisms into the incision site, for example, by using adequate wound dressings. I thank you for listening, and I'm really pleased that I could be part of this very good piece of work by EWMA. Thank you.
Hello everybody, my name is Janstria. I'm a vascular surgeon, former EWMA Council member, and editor of the EWMA-SSI document. In my presentation, I will enter into our webinar with the clinical classification of surgical site infections and surgical wound classes. The majority of surgical wounds is closed at the operating hall and healed by primary intention. To be able to fix wound margins by stitches, staples, or glue, it's necessary to obtain clean incision, uncomplicated course of healing, and the incision has to be closed up to 24 hours after the opening. For clinical diagnosis of surgical site infection, it's necessary to find relevant signs and symptoms of infection at the site of surgery within a defined period of time. Refer to EWMA-SSI document and other literature. The infection has to make evident up to 30 days after surgery or up to 1 year after implant retaining surgery, where the implant is defined as a non-human derived implantable foreign body that's permanently placed in a patient during surgery. The signs of SSI have been discussed in previous lecture, so the process of making diagnosis should be clear, as you can see in this picture. But SSI staging needs more vigilance and prudence. SSI surveillance gives the feedback of appropriate data to surgeons, so its impact is huge. For the surveillance purposes, we follow the CDC SSI surveillance protocol published on the CDC website. The conditions of acceptance are similar, but the CDC protocol recognizes 90 days after implant retaining surgery. Day 1 is the procedure date. A laparoscopic trocar site is considered a surgical incision, and stitch site infection or abscess alone are not considered as a SSI. Due to the range and localization of infection, 3 types of surgical site infections are defined: superficial and deep incisional SSI, and organ or space SSI. Clinicians responsible for SSI recognition should be familiar with the wound anatomy. He would know the extent of the incision, the topography of the surgical site, use surgical technique and wound classification, because his expertise helps to find right diagnosis. The use of valid definitions and classifications is essential, and we refer to relevant ECDC and EWMA documents. In superficial incisional SSI, infection involves only skin and subcutaneous tissue of the incision. In deep incisional SSI, infection involves deep, soft tissue of the incision, especially fascia and muscle layer. In organ space SSI, infection involves any part of the body other than the incision opened or manipulated during surgery. In this picture, you can see clear clinical signs of a subacute infection of abdominal wall in a woman after laparotomic hysterectomy. She is after re-examination and of the incision with relapse of the SSI. Even though the diagnosis of infection is easy, for setting the stage of SSI, we need more assessment. Clinical examination comprises careful surgical inspection of the wound, revision of the surgical site, and the usage of other imaging processes like ultrasonography, CT, MRI, or PET-CT. 50% of reported SSI are superficial incisional wound infections. They affect skin and subcutaneous tissue of the incision. The left picture shows superficial incisional wound infection at the place of a laparoscopic trocar site. In the picture on the right side, you can see superficial infection after umbilical hernia open repair. The last picture shows iconography of superficial infection of femoral fibular bypass close to the knee area with purulent discharge. The prosthesis has been placed just below the skin. This SSI can be categorized as a superficial infection, but infections of vascular reconstructions used to be better classified by Shilagi, in this case, grade 3. In some disciplines and clinical situations, the usage of CDC classification L1 can be insufficient, and it's recommended to use specific ranking. Another example of superficial incisional SSI is infection of the pocket after pacemaker placement. In the right side picture, you can see infected vascular reconstruction at the place of its distal anastomosis. The anastomosis is placed below the crural fascia among the muscles, so the SSI is classified as a deep and, according to Shilagi, as grade 3. So don't presume on the first side in sorting the SSIs. Deep incisional wound infections are reported in 30% of all SSIs. They affect deep soft tissues of the incision, including fascia and muscle layers. The iconography presents typical examples from vascular and abdominal surgery. We can mention that the square extent of the infection does not directly affect its depth or possible striking the organs. And in this case, we describe only deep incisional SSIs. The same as here, in a patient with deep infection of ischemic stump after major amputation of the right limb. Organ and space SSIs make 20% of reported SSI. Infection affects organs other than the incision opened or manipulated during surgery. In the left picture, you can see patient with stercoraceous leakage and peritonitis after colorectal surgery with open incision. The right picture demonstrates a patient with infected aortic graft before its explantation. The diagnosis of organ SSI has been confirmed by PET-CT. In what clinical situations it's not an SSI? As an example of misdiagnosing SSI, we can show stitch abscess or infection connected with the suture material. The clinical view makes normal fast after the stitches removal. At this slide, we can see examples of wound dehiscences. The clinical signs of infection are lacking, or wound dehiscence resulted from the mechanical failure of the sternotomy. Wound classification is an important tool for assessment the operating risks for the patient before surgery. Thanks to this, we can adapt the preoperative preparation of the patient in case of unexpected preoperative accidents like major break in aseptic technique. We can re-evaluate the wound class and right away adjust the procedure or apply antibiotics. Surgical wound classes has been published in 1964 by Brett and Grandin, and they are still valid and in use. Clean wounds are characterized as an uninfected operative wound without any inflammation, and the respiratory, alimentary, genital, and urinary tracts are not entered, and no break in aseptic technique during operation has been noted. Clean wounds are primarily closed if it's necessary, they are drained with closed drainage. As an example of clean wound, we can give open and arterectomy of the internal carotid artery. The risk of SSI development is very low and ranges from 1 to 3%. Clean contaminated wounds are operative wounds in which the respiratory, alimentary, genital, and urinary tracts are entered under controlled conditions and without unusual contamination. There is no evidence of infection or major break in aseptic technique. As an example of clean contaminated wound, we can give nephrectomy due to malignancy or planned appendectomy. The risk of SSI development ranges from 3 to 10%. Contaminated wounds are open, fresh, traumatic, and accidental wounds, operations with major breaks in aseptic technique, or with gross spillage from the gastrointestinal tract. Incisions with acute non-purulent inflammation or presence of necrotic tissue, but without any evidence of purulent drainage. The risk of SSI development is up to 20%. Dirty or infected wound. Those wounds are surgical wounds with acute purulent inflammation, operations involving existing clinical infection, perforated viscera, or fecal contamination. The risk of SSI development can range from 20 to 40%. To summarize the wound classes chapter, we can state that the most important advantage of setting the wound class in the patient is a chance to tailor the intervention and to reduce the risk of SSI. Different medical disciplines use different sets of questions. In vascular surgery, the algorithm can include topics such as, is the surgery the best way how to improve patient's health condition? Shall we use endovascular or surgical approach? Are we able to reduce the risk of SSI by surgery itself? Is it feasible to use vein graft or prosthesis? Are we able to individualize preoperative preparation of a patient and to ensure better timing of the operation? More questions would be too provocative. So I'd like to thank you very much for your attention, and I'm open for all your questions.
Thank you very much for the presentations. We will now move on to the questions from the audience. If you have any other questions, please type them into the Q&A box. I have one question here. It goes. It is around the prevention of the wound, of the surgical site infections and the wound dressings. Deborah, for example, you said that negative wound pressure therapy can be applied. According to your experience, what kind of other dressings would do you use, or then after it's Jan, for to prevent surgical site infections?
Jan, maybe you like to answer this?
Okay, so I think that it's not necessary to use antiseptic dressings for prevention, because the use of antiseptics is connected with the risk of allergy or absorption, for example, of the iodine. So I guess that the best feature of dressing is to be a barrier and to be able to absorb exudation or blood from the wound. So I prefer dressing without antiseptics and only protecting the surface of the wound.
I believe also the evidence agrees with what you're saying, Jan. There is no need for antimicrobial dressings as a measure to prevent surgical site infection.
Yeah. And in some clinical situations, we can use, for example, incisional negative pressure therapy. And it's it has a logic because when I have a high-risk patient, it's better to use the best technique for wound closure and for protection of the wound. But the problem is that to use this incisional negative pressure in each patient, it's too costly. So we are not able to use this treatment for each patient. So it's about screening the most affected or risky patients.
Thank you. There is another question from the audience. They ask, with your experience, what or when will you recommend for antiseptic use during wound dressing changes?
Well, it's used to use antiseptics during the dressing change, during the checkups, during the visits at the surgery clinic. So it's something not in the rules, but we use it. But on the other hand, for prevention or for the best management of post-operative wound, we know that this barrier function is the most important. And after 3 days, patients can wash. So there is no sense to use antiseptics. So I guess that this is up to some national standards or the best experience of the surgeon.
I would think that when there is some evidence of an infection, that's when this would be indicated. And of course, depending on the kind of wound and also the organism which would be causing the infection.
I would like to come back to the question before we were discussing. Somebody is asking, what if there was a cost-effective incisional negative wound pressure therapy device? Will it gain broader adaptation?
Well, incisional negative pressure therapy can help to adapt the margins of the wound, and it also reduces the edema and helps to manage wound exudation. So if we take into account those factors, yes, it's cost effective.
Mm-hmm. Please note the questions in the Q&R section. I see it mostly in the discussion. I take another question here. Is there any tool, score or similar, to assess the risk of wound dehiscence for the use of incisional negative pressure therapy? Any comments to that?
I wouldn't know how to answer that, unfortunately.
Mm-hmm.
I think it's again about choosing the high risk patient, because if I know that some patient is under the anticoagulant therapy and the risk of surge space development in the wound is high, I can use negative pressure primary. So it's something like delayed wound healing, delayed closure of the wound. So if there is a high risk of collection of blood or fluids or high risk of wound dehiscence, I can do it. It's up to me.
I think it's a tool to assess the risk of wound dehiscence. So that means, did you have a tool that you assess? That you assess?
No, we haven't.
No. There is another comment. Frailty index can predict wound complications. The accuracy of the modified frailty index to predict wound complications is as follows. Sensitivity, it's 53.9%, specificity 74.8%, positive predictive value it's 50%, and negative predictive value is 77.6%. Thank you very much for this comment. We are coming already to the end of this webinar, and I would like all to thank for taking part of this webinar, especially the three speakers. Don't forget, you will be able to access the video recording of the webinar on demand via the EWMA website within a few days. We hope that you will join us for one of the next EWMA webinars. The next webinar is the second episode in the surgical site infection webinar series, and which will be held on December 7th. This webinar will focus on the treatment and management of surgical site infections. You can keep yourself posted about future EWMA webinars via the EWMA newsletter, our social media, or our website. Finally, we hope to see you all at the next EWMA conference in Paris that is taking from the 1st to the 3rd of February 2022. Thank you again for joining. Stay safe and have a good evening. Bye-bye.